we approach April, which is actually increasing by leaps and bounds, till it actually begins to now overtake the biggest killer worldwide, which was malaria, by early April. This infographic goes on till about the 25th of May, and we are now on the 10th of June. By this time, we have actually, by May 25th, we've had about 343,000 deaths. We are now significantly over that, over 400,000 deaths have actually been crossed. So this exponential growth has, of course, affected all the regions of the world. But let's focus on our part of the world, which is Pakistan, India, Bangladesh subcontinent. So we have seen up till now about 9,000 deaths in this region, which is with about 350,000 infections at this point. At the rate at which the infections are going, in Pakistan is at 27%, Bangladesh is at 19% rate, and India at 17%. The predictions are that our numbers are set to double every 2 weeks. So by the end of July, we may be crossing the 5 million infection mark and over 150,000 dead. Now, if you look at it in perspective right now, America is at the top of the list of people who are infected and who actually passed away at 100,000 plus. We are set to become the next hotspot with this densely populated portion of the world. And we'll probably be, at this rate, exceeding the US and Europe probably combined. Right now, predictions are like Delhi, for instance, which has a similar population as Karachi, will be in a few weeks having more than 500,000 people infected. Pakistan has one of the top 10 slots in the COVID top 10 charts, unfortunately. WHO, which had earlier praised Pakistan some weeks ago for its efforts in controlling pandemic earlier on, now is saying, and I quote this from today, as of today, Pakistan does not meet any of the prerequisite conditions for opening the lockdown. However, reality is that there is no lockdown for whatever reasons, economic reasons, pragmatic reasons, whatever you might call them, political reasons. And there is no lockdown in Pakistan, and similar situations exist in India and Bangladesh also. So COVID-19 has become very personal for us. Everyone we know has either had an infection themselves or knows someone very close who has suffered or is suffering this infection. So with this backdrop, we thought it was important to invite our three speakers. These are experts in their own respective fields to share their perspectives on how we should go around taming this pandemic. I would like to introduce our speakers. We'll have three speakers, Dr. Amber Mehmood, Dr. Richard Cash, and Dr. Keymanthri Moodley. And they will be talking in this sequence. All three speakers will have about 20 minutes, and with about 10 minutes or so following their talks for a question and answer directly to them by the audience. So let me start with their introductions. Amber Mehmood is an assistant scientist at the Johns Hopkins Bloomberg School of Public Health. She has previously served as Associate Director for Johns Hopkins International Injury Research Unit and has served as a WHO Euro Office for Disaster and Mass Casualty Incident Management Capacity Development. She has also been a technical consultant for the World Bank on road safety and post-crash care. She has recently worked as a Situation Assessment Chief at the Johns Hopkins Unified Command Center for COVID-19 for building surge capacity and plans for enhancing care capabilities across all Hopkins medical institutions. Dr. Amber trained as a general surgeon, but found the canvas too small, I believe, which is why she's now having a much larger global canvas to work on. Her talk will be on COVID-19 pandemic response. Do social realities override an evidence-based approach? So the second speaker after her would be Dr. Richard Cash. Dr. Cash is a senior lecturer on global health and development of global in the Department of Global Health in Population in the Harvard University. He is known for his work in the development of oral rehydration therapy for both children and adults. He has been a director of a Fogarty grant, NIH grant for research ethics training that focused on developing fellows from Asia. And he's had numerous research ethics workshops conducted both at the Harvard School of Public Health in Boston and across the world, including many times in Pakistan, India, and Bangladesh. He is a senior editor of the Casebook on Ethical Issues in International Health Research, which is a WHO publication. So he has extensive experience in dealing with public health and public health ethics issues in the subcontinent, having been spending a lot of time in this part of the world. He is also our associate faculty at CBEC and has come to CBEC to teach public health ethics many times. He's also our faculty at the CBEC Kemri Bioethics Training Initiative, which is based in Kenya, a collaborative program of CBEC and Kemri, again funded by NIH. His talk will be on Has COVID-19 Subverted Global Health? Very provocative topic. Dr. Keymanthri Moodley is professor in the Department of Medicine and director of the Center of Medical Ethics and Law, Faculty of Health Sciences, Stellenbosch University in South Africa. This is a collaborative center of bioethics with the WHO, as is our own center, CBEC. In 2017, Dr. Moodley was appointed adjunct professor in the Department of Social Medicine, University of Northern Carolina, Chapel Hill in the United States. She specializes as a family physician and a bioethicist and has been practicing family medicine for over 25 years in both public and private healthcare sector in South Africa. She is also a principal investigator of many clinical trials in the past decade. As I mentioned before, she heads the WHO Collaborating Center for Bioethics. Her talk will be entitled Pandemic Planning During COVID-19 in Africa, Utility and Justice from the Bottom of the Pyramid. So I would like to invite Dr. Amber to start the proceedings with her talk. Amber, you can unmute yourself.
Hi, everybody. This is Amber. And thank you very much for inviting me for this very, very exciting session for me and very close to my heart. For two reasons. One, we are seeing a lot of burden of COVID-related mortality and morbidity in United States, but now the epicenter of the disease is going to shift in South America and South Asia. So this is a very, very timely talk. And I thank you for organizing this talk as well as inviting me to be a part of it. I will now share my screen so that you can see my slides. Just a second. Can you, Dr. Amar, can you open my slides?
Just hang on. Maybe you're not the host yet. We'll just make you host.
I'm doing it from my end. She is the host. Yeah, doing it.
Can you do it now? Can you see my slides?
I've shared the slides.
Oh, thank you very much. Okay. So thank you for your attention and for your time. I'm sorry about this glitch. So first of all, I would like to say that I don't have any conflict of interest. I'm not representing any commercial or political interest at in this session. Dr. Amir set the stage by telling us that how quickly this disease has taken over the global mortality and sort of surpassed all the other major killers so far, whether in the high income countries or low income countries. But still, when we look at the disease itself, we know that this is a poorly understood disease. Initially, what we understood in the beginning of the pandemic, that understanding has now changed a lot, and it continuously changed. Started off that with the notion that probably coronavirus is like a flu, and many people actually believe that. Initially, we also believed that it's only spread through droplet infection, but now we know that there is airborne transmission. We thought that there's mild disease in young and healthy people. This is nothing to worry about. But later, we learned about asymptomatic carriers, pre-symptomatic super spreaders who were responsible for big clusters in major crowded areas. We also thought that only elderly and immunocompromised people are at risk, but now we know that there are rare presentations in children, especially with immune system problems. And then what we thought that it is a solely respiratory illness has now changed into a different understanding. And now we are learning that there are many atypical presentations, and there are a constellation of signs invoking multiple organ failure and manifestation of cytokine storm. So before we go into the details of what strategies and what medical treatments we have in hand, let's talk about what is the goal of coronavirus pandemic control. The first thing that we have to remind ourselves that when we are talking about an infective process or a disease that can be communicable, can be communicated from person to person, then one of the things that determined its fate is the R0, or basic reproductive number, as we call it in epidemiology. The R0 is an indication of the transmissibility of the virus and denotes how many people can be infected from one primary person who becomes the spreader. The second important thing that we have to remember is that if we don't do anything, the R0 of SARS-CoV-2 virus, which is what we are talking about today, has been found between 2 and 3 in various parts of the world. The third thing that is important is that to control the disease or control the the transmission, the R0 has to be kept below 1. It means that if a person gets infected, he or she doesn't infect more than one person around themselves. If that can be achieved for long enough, usually a few weeks, and there are many things that can help us do that, like social distancing, quarantine, etc. The number of new infections begin to drop, and containment is slowly achieved. This is what dozens of countries around the world did, before easing their lockdowns. This slide actually talks about the medical countermeasures that we have so far. And there are a number of things that you would want to know. One of the most important things is that all of the medical countermeasures are still in a trial phase. There is no single drug that is proven to be effective in reducing the mortality or effective in stopping the transmission of the disease. Most of the medical countermeasures that I have just listed here, remdesivir, interleukin inhibitors, and convalescent plasma and immunoglobulins, are used for people who have severe disease, who are hospitalized, and also in many places they are cost prohibitive because of their, huge cost. So to be honest, this is where we are, that we don't have a cure, and all we have to think about is either whether we develop a vaccine or we develop other strategies to control. As far as the vaccine is concerned, there are over 100 vaccines, trial. Some of them are in trial phases, some of them are in development phases. The first trial that was, that showed some promising results was reported in May 22. But still, there are other trials going on, and important thing is that how effective this vaccine would be in stopping the transmission. And the one of the things that people have been trying to advocate is to speed up the trials, and some of the trials that they are suggesting are of dubious ethical value in terms of infecting healthy people, and then seeing whether the vaccine works or not. So that's a debate of another time. I'm not going into the details of that. But important thing is that the longevity and protective capacity of antibody response depends upon how effective the vaccine is, and the best bet would be anything that neutralizes antibody, that produces neutralizing antibodies against SARS-CoV. Another important point that you have to remember is that despite initial successes, it will take a lot of time to produce any viable vaccine with the ability of mass production and coverage across the world. It's also important to understand the maintenance, the logistics, the cost and market hurdles, regulatory problems, before we can say that, oh, by the way, we have now developed a vaccine and we are ready to go. So the important thing that we have to remember now is that we are left with non-pharmacological countermeasures at this point. And not having a medicine that's, works for sure, not having a vaccine that can prevent uninfected population from getting infected, leaves us with very little options to play with in terms of controlling the disease and controlling the transmission of this pandemic. To keep the R0 below 1, there are things that we can do, for example, wearing masks. And we know that now there are studies that show that personal hygiene, wearing masks, can effectively prevent the spread of coronavirus, especially if you use these masks within your homes. And this was something that when we started, we just said that when you go outside, when you go into a crowded place, when you are meeting with other people, you have to wear masks. And there are other things that come into play, whether you're using N95s, whether you're using surgical masks, etc. But anything that works as a barrier would be effective in at least slowing down the transmission from person to person. There are studies that show that household transmission was 18 times 18 times higher. The household transmission, can be slowed down, but also there are studies that show that even if the household was crowded, wearing masks can be effective than not wearing at all. The second important strategy that has been, advocated a lot is the testing, tracing, and isolating strategy. The process of identification of persons who may have come into contact with a coronavirus patient is important. And then it's not just that you identify those people and that's the end of the thing. The important part is you don't only identify, you test them, and then you isolate them. So case investigation is a part of the process of supporting patients with suspected or confirmed infection. The thing that most of us don't realize is that contact tracing is a specialized skill. It takes a lot of time, diligence, cultural sensitivity, confidentiality, patient privacy, and education, information, and support to not only the patient but also the contacts. And this is, if done correctly, this could be a game changer. If not, then it leads to a lot of stigma and a lot of cultural and societal pressure that leads people to not telling about their disease or about their contacts. Time is of essence in this strategy. The sooner you get to all the contacts, the better. And important priority settings could be different in local contexts, like in healthcare facilities, group home, etc. Especially the hotspots that have emerged in United States, as we all know, are shelter homes, nursing homes, correctional facilities, but in very in societies like South Asia, where multi-generational housings are common, this could very well be a strategy that can work. Social distancing and sheltering in places have emerged as a key strategy in bending the curve. So initially, when the pandemic started, we heard a lot about we have to flatten the curve, and nobody knew what flattening does and why are we advocating for that. So important part of social distancing or similar strategies is that it doesn't only buy you time. So this was not the goal. The goal was to keep the R0 below 1. So please, clear your mind that these things can only help you buy time. Interventions that started earlier in the epidemic delay the epidemic curve. The interventions that start later flatten the epidemic curve, but both help you keep the R0 below 0, below 1. Another important thing that you have to realize is when United States and Europe were seeing their epidemic curve go up, they were already in the disease process pretty far in. So for them it was flattening the curve, and there are many reasons why it happened. but at least when they started and rest of the world followed, we thought that this is the right time for everybody to start social distancing or lockdowns in some parts of the world, without realizing what we are actually going to achieve. So if you start early, you delay the epidemic curve. If you start late, you flatten. But at the same time, you have to design your strategy in a way to understand what you're doing and how far or how frequently you would employ these strategies in your own context. So many people said that, oh, it doesn't really help us, and it doesn't make any difference. But many studies are now out that shows that while social distancing interventions were in place, many hospitalized cases and many deaths were averted. And it was, for example, this study showed that, depending upon how long you implement the social distancing, and whether it's whether this social distancing started earlier in the epidemic curve or late, it shows how much impact it has on new cases, hospitalizations, and also in deaths. And it showed that during first 100 days for various social distancing scenarios, in which adults reduced their contact by 25%, 75%, and 95%. These bar graphs give you different scenarios. Two important studies that came out just like 2 days ago, literally, were on the impact of large-scale anti-contagion policies on the COVID-19 pandemic. And I'm showing you two graphs here. One of the graphs shows you the top graph actually is infection growth rate without policy. And this study, which was published 2 days ago in Nature, actually compared 6 countries: China, South Korea, Italy, Iran, France, and United States, which actually got into the pandemic really early on. And the top graph actually shows you that if you didn't do anything, what was the daily growth rate expected in these countries. And a lot of these growth rates in each country were prevented by implementing policies. And here you can see that the policies that included lockdowns, school closures, avoiding crowded places, wearing masks, and personal hygiene prevented additional confirmed cases in all of these countries, and resulted in 62 million additional cases that were prevented by these policies. And these 62 million cases, you can imagine that if they were not prevented, what kind of havoc they could have brought into the situation. And this is only 6 countries in which we are estimating 62 million new cases that were averted. Now, magnitude of these impacts obviously reflect the timing, the intensity, extent of the policy deployment. That, whether this was a national policy or staggered policy, or some essential businesses were allowed or not. but still you can see that it had a huge impact on disease containment. The second important study that came 3 days ago was based in Europe. And this was a study that included, major 11 major European countries, and they studied different types of non-pharmaceutical interventions such as lockdowns, public events, school closure, self-isolation, and social distancing, etc. And it showed that at least 3 million deaths have been averted due to these interventions. And remember that when this all started, UK, Italy, France became the hotspots, and especially Italy employed lockdowns early on, and there was a lot of talk about other countries like Sweden, which did not go into a lockdown, and what benefits they had by avoiding it. But it turned out that if they had not done this, there would have been additional 3.1 million deaths. And amongst all of these,
Amber, you've used up 20 minutes, so maybe a couple of more minutes you could wind up so that then we can take some questions also.
Yes. And all of these interventions, amongst all of these interventions, there were, lockdowns, which were the most effective. So there are other countries that did well. For example, South Korea, that employed its testing, tracing, and isolating policy very, very effectively. There was Vietnam, which is a low middle income country, very effective in containment of the disease. So far, there are only 332 cases and no deaths. And they employed tracing and quarantining without much testing. And they use a lot of their national health systems strength to achieve this containment. Important things are that help you understand that pandemic control is not a health service delivery issue. When do you actually start your policy implementation, whether your policies are national or subnational? Do they have any economic support in your policies? How stringent they are will dictate the country's infection trajectory. So on a scale of New Zealand to Brazil, and in between there are Indian states like Kerala and Vietnam. You can choose your trajectory and you can choose your own policies and strategies. The countries that more efficiently managed their first outbreak and its consequences banked on their public health preparation and response to mitigate the impact. It was not because of their universal health care or fancy treatment or very advanced facility-based treatment. It was their public health response that helped them come out of this pandemic. There are unintended consequences, we all know that. And this is why we are having this conversation today. But my urge would be to think about if we have some effective interventions and policies in place, then we cannot turn our heads to the other side and say that, this works in another country, so why should we even think about it or try that? Contextual differences matter. but you have to find some way to address them and keep your community leaders in the loop. There is no trade-off between saving lives and economic growth. Saving lives come first and economic growth follows. Disease control does not mean that there will be no new cases. There will be flares. But when you achieve control, you know where these flares are and you can control them. So it's not a flat epidemic curve all along when you say that we have achieved the control. You have to prepare for the flares, and you will have to prepare for the, according to the local context. And finally, whatever you do, put public health at the center of prevention, control, and response. This is not the first time, and it won't be the last time that you witness an emerging disease posing a global threat. So what you have to do is to trust data, listen to the science, and plan ahead. Think about your own context and think about the strategies that can work in your own context. But denying that this will not happen to us, or we cannot even think about the control, is not the right strategy to do. I will stop here with a quote by the Liberian president, Sirleaf, who said that, and she was the one who was the center, who was leading the Ebola epidemic in 2014-15 time in Liberia. And she said most recently about COVID-19 that an uncontrolled contagion, no matter where in the world and no matter how localized it is a threat to all of humanity, and we have to fight it together. So with that, I thank you a lot for your attention, and we'll be happy to answer your questions.
Thank you. Thanks a lot, Amber, for a very informative talk. We've had several questions coming in, and I think we should go straight to the questions. Swaleha, can you feed in the questions, please?
Yes, so we have around 7 to 8 questions. I'm going to take as many as possible in the next 10 minutes. And so Dr. Moazzam has asked you, Dr. that define social distancing in the West. This is often not going to pubs, restaurants, etc. How is social distancing to be understood within the context of LMICs, where 10 or more people live in 2 rooms? Hygiene measures for COVID would be impossible in countries like Pakistan and Bangladesh, as defined currently in international literature.
Yeah, this is a very valid concern, and we have thought about it a lot. And this is super difficult in situations where people share, rooms, residential complexes, share restrooms, and are, very, very difficult to achieve social distancing in real sense of the word. I think none of these strategies work perfectly alone. So if we are only relying on social distancing and not personal hygiene, and if we are not, wearing masks and thinking only social distancing would work, then it would not. So everything comes together. And even though that, social distancing in some situations might not be possible, in those cases, maybe we should encourage people wearing masks. And, at least this is the basic minimum that can be done. Now, thinking that one thing would work and other would not, all of these non-pharmaceutical measures are not perfect. And a combination of these things might work the best, but at least we can try with some measures which can work in one place and some which can work in another. At least there would be some break in the transmission. But if we think that nothing can be done, then obviously nothing would work.
Okay, so there's another question from Dr. Natasha Anwar from Lahore. and that's with respect to the contact tracing that you mentioned. Private labs are required to provide patient contact details of all cases negative and positive to the health department. Recently, we have been approached by district commission officers for data on everyone booking a test at a private lab. How does provision of data off to multiple parties affect privacy, confidentiality, and integrity of data?
So recently, so you are representing a private lab, or?
It's a private lab, yes.
Okay. So actually, these are reportable diseases. So pandemics and any reportable, infectious disease is a reportable disease, and district health departments need to know for surveillance purposes that you have these cases, and you have to. So the thing is, in countries like Pakistan or other parts of the world, the surveillance is so weak, and the surveillance infrastructure is so weak that we have to think about where should we report. If the district health department is asking you for data, first of all, there has to be an infrastructure where you can actually automatically provide them data. But if they're asking, you have to, because this is a reportable disease.
Okay, so there's another one from Kampala, Uganda, from Dr. Kibuka. I hope I'm pronouncing your name right. My question is, what is the maximum number of viruses that an infected person can spread to another person in one single touch?
One single touch? I think there have been, so the average number that we have come across is between 2 and 3, if nothing is done. No pharmaceutical measures are non-pharmaceutical measures have been implemented. But there have been reports of super spreaders in which a single person has infected actually dozens of other people. And that happens in usually very crowded, closed spaces, or where one person has the potential of meeting a lot of different people because of their job or their setting. So for example, in South Korea, there was a patient number 31, case number 31, who managed to meet about 1,000 people in a week's time. And she was called the super spreader because she alone was responsible for a major cluster of disease because of her job. So depending upon how, if you are living in a domestic environment, the maximum you can do is to, infect a few people. But if you are exposed to a lot, then the number can go a lot higher.
So I think we've got several other questions, but I think we're running short of time. I just wanted to ask very briefly, Amber, if you could explain, how do you explain Vietnam?
Oh, Vietnam is a very fascinating country in terms of pandemic control. So Vietnam's response was entirely based on their preemptive and public health centered policies. By the way, Vietnam is just next to China. So, and there are multiple flights from Vietnam to Wuhan and Wuhan to Vietnam every day. And when they first heard about this infection back in January, that's when they actually started working on their strategies. And by February 1st, when they had only 5 people coming back from China, and as the cases, they declared a national emergency. you know, a plan to implement contact tracing, isolation, quarantine, border control, you know, social distancing, stay at home, encouraging people to stay at home, isolated lockdowns, and kept their you know, transmission very, very low. They had no deaths, and the total number of cases until now is 332. So they actually contact traced approximately, you know, 120,000 people and isolated them. And that's how, you know, they controlled it before. They did not rely on heavy testing. They didn't have that kind of infrastructure for testing. Also, I would like
maybe a smaller.
One more point. Their policies were national. There was no, you know, provincial, states, etc. Discrepancy. Number two, they very, very early on they started warning people. The messaging was consistent. The messaging was very, very strong. They actually used very effectively their state propaganda apparatus to involve people, send them messages, TV programs, radio programs, and that helped a lot in getting people on board early on.
So thank you, Amber, for a very interesting talk and some questions that you answered. And of course, we'll return to you and the rest of the panel after all three talks. But we should now move on to the second talk, which is by Dr. Richard Cash. Richard, you'll have to unmute yourself and you can start.
Okay.
Do we have Richard?
Yeah.
Yeah, okay.
Okay, thank you very much. It's a pleasure to be back, even virtually, in Karachi. I can't remember when I was last there, maybe a year or two ago. I can't, somewhere in that vicinity. And certainly I've worked with CBEC in Kenya, I think it was a couple of years ago that we were together. I'm going to take a somewhat different view of Amber's presentation. And in fact, some of the positions taken by some of the global participants in this. In May, I co-authored an article with Vikram Patel, basically saying, has the COVID-19 pandemic subverted global health? And we concluded that, in fact, it had in a big way. And our basic premise was that context was critical and social justice was critical. And both of these were lacking in many of the responses throughout the world, especially, I might say, in South Asia, which, after all, between Bangladesh, India, Pakistan, and a few of the Sri Lanka, Nepal, and so on, represent a fifth of the global population. So we're talking about a huge swath of people. And why did we take that position? We felt that, contextually speaking, the approaches that were being used in the US, Western Europe, and East Asia were not appropriate for South Asia and for, I would say, for Sub-Saharan Africa as well. The demography was totally different. A much higher percentage of individuals were less than 20 years of age. One of the things that was not mentioned in Amber's presentation is who gets infected. In Massachusetts, where I live, a small state with 7,000 deaths, so we have 3 times the number of deaths that Pakistan does, and we only have 7 million people. Pakistan has 220 20 million people, there are no deaths in anybody under 20 years of age. And in fact, under 40 years of age, under 50 years of age, of all of those 7,000 deaths, only 1.4% of those deaths are in people under 50 years of age. So the demographic profile is absolutely critical. If you have nobody who's old, which is where most of the deaths are occurring, and lots of people who are young, the number of deaths that you will have will be significantly affected. And after all, what is the purpose of what everything is we're trying to do? We're not trying to really prevent cases. If all the cases lead to nothing, no deaths, if all of the infections, rather, not cases, all the infections are in people under 20 years of age, and there is no mortality in that group, who cares? Yes, there'll be a few rare instances of mortality in the under 20, but is of no public health consequence. So it's not the number of infections. It's not even the number of cases if most of the cases are mild. The only thing that matters are very severe cases, and deaths. That's what we're trying ultimately to prevent. Okay, so the demography is totally different. Very few elderly, lots in the younger age groups. Secondly, the way people are living is absolutely critical. Many people per household is a risk, but over 60% of the deaths in Europe and the United States occur in chronic care facilities and old age homes. 60%. Let me repeat that. That means that if you have lots of old age homes where you're crowding elderly people together, and they are often treated by or cared for by people from lower income communities which have higher infection rates, then you have a natural event taking place where the highly infected are taking care of the highly vulnerable. That does not exist in South Asia. We do not have lots of chronic care facilities. The elderly are treated at home or treated in separate or live in separate housing. Thirdly, the quality of healthcare throughout South Asia is not very good. The percentage of government spending for healthcare, whether it's in Pakistan or India or Bangladesh, is around 1.5%, extremely low. The health system has already been under surge. I mean, every day, all of the, I saw one statistic out of the best hospital in Dhaka, out of 500 people who came in for, who should have been admitted, they could only admit 100. This is pre-COVID. So there was already surge, if you will, because there was, secondly, there's not much you can do for people who are severely ill. You can provide ventilation. The number of effective ventilators in Pakistan must be probably less than 500, if there are that many, and functioning ones, and people who know how to run them is very low. And of those people in high-income countries, I think in Massachusetts, 70% of the people who were on ventilators died. So it's not like ventilators are providing some sort of panacea. For the vast majority of people, they are irrelevant. What should be developed probably is an appropriate type of ventilation system like the bubble ventilator that has been developed at the ICDDRB in Dhaka, but is for pediatric patients. Can this a similar type of thing be developed for adults and so on? So the demography is different, where the elderly are treated, are cared for, are different, where the health sector is very different, and then the capacity to even screen, to test, and so on is a fraction of many of the other countries. Lastly, they all got into the game rather late, when the early approaches that have been championed in whether it's South Korea or take your own region of the world, Sri Lanka, Kerala state in India, and Nepal, interestingly enough, all of them have less than 50 deaths. They're no different than East Asia, but all of them began very early. And I might add, Kerala, which I know quite well, and Sri Lanka, all of them had a very, very strong social network system, been developed over many, many years. So people who were confined to their homes, who needed things, could be looked after by the state in a very, very effective way. So Kerala and Sri Lanka are where you ought to look. You ought not to look at Vietnam and South Korea. Look in your own backyard. But all of those places began early on in the outbreak. Now, so context is critical. Let's take a look at the other issues, social justice. The problem with the strategies that have been developed outside of South Asia is that social justice has been the victim here. That is 90%, 85, 90% of persons in Pakistan and whatever are living on a daily wage. They are daily laborers. They're not getting a salary like me or Amir or any of the people on the panel. We all get a salary. If we have to stay at home, we have nice quarters to live in, okay? If we have to stay at home, we can have food delivered. If we stay at home, we have space. That's not the case of most of the people living in South Asia, and I take South Asia in totality, okay? So the virus may affect an individual human the same in terms of our physiology, but it doesn't affect us similarly when it comes to our vulnerability. Our vulnerability is very much affected by our social position in the world. So it is not an equal opportunity infection. It affects people, and the intervention affects people in a very, very disproportionate way. So you take people who are on a daily wage and you say, I'm sorry, you can't work for the next 2 months. Where are they going to get their food? The state is going to supply it to them? Please. I've spent a lot of my life in South Asia. I know the reality. That's not going to happen. And it hasn't happened. Yes, there are a few food distribution points. Take a video of those food distribution points and see what happens. People crowd together. They don't stay 6 feet apart. When people were forced to go home by the state, a police action, I might say, not a public health action, a police action, millions of people streamed home, some walking, some by foot, some by train, some by bus, what have you. So there was a mass crowding of people back in their home. Take a look at the slums of Karachi, of Mumbai, and so on, where many families live in a single dwelling, and we're up to 100 families may use a single toilet. And you're going to tell me, and by the way, the term social distancing is the wrong term. It's physical distancing. Social distancing is what we're doing now. We're scattered all over the world. We're talking about physical distancing, not social distancing. So we should change the words that are being used. So the impact, then you have a fragile health system. And so people can't get to that fragile health system because public transport isn't available. Okay. So what happens? And this has been well documented. It was well documented in the Ebola outbreak. I'm surprised we haven't taken a page from what happened there. Health systems, generally speaking, begin to implode. People stop going to the clinics because they're afraid. Immunizations go way down. Treatment for tuberculosis goes way down. Treatment for chronic diseases goes down. So in fact, the mortality associated with lockdown situations far, far exceeds that is caused by this particular virus. I can tell you that, and you know yourself, that basic health services, in fact, my guess is that at SIUT, hospitalizations are down because people are afraid to go to the hospital. The one virus that has been the most effectively transmitted is fear. Fear has completely infected the population, spurred by government misinformation or poor information and an aggressive press, which has, I think, oftentimes misconstrued messages. So what does fear do? Fear stigmatizes people. Fear stigmatizes institutions. Fear stigmatizes providers of care. Fear stigmatizes your neighbor. So why would I go and be tested for a virus when I know that I'll be confined to my house for 2 weeks if I'm positive and maybe beaten up and thrown out of the village by my neighbors? What is the incentive to go in and get tested? So in terms of, and then I haven't even mentioned schools. Why have we closed all of the schools? This is not a disease of young people. They say that young people will infect older people. The fact is that despite the hemming and hawing of WHO, there is not a huge degree of transmission between the very young and others, both because they don't cough in the same way and because they're not nearly as infectious. Yes, you can be infectious in the asymptomatic phase, but that's not where most infections are occurred. So we've shut down health education institutions. And by the way, most kids can't use a computer to stay up to date. They can't zoom in on their classes. My own take on this, which will be very uncomfortable to many, is that this has been a policy pushed by the middle class who feel vulnerable. But it is the lower classes that have been most affected by the strategies that have been undertaken. And so I feel that then you say, okay, well, what can we do? Should we just do nothing? Should we just throw up our hands? Is it all hopeless? Well, that's not what we're saying at all. What we're saying is that you should craft your intervention to your situation, to your demography, to your resources, to what you can do, not what others can do, but what you can do. Now, what does that mean? Well, it means that, yes, masks are very valuable. Unfortunately, the public health community initially said, oh, masks don't work. That was a very self-serving policy to save masks for treatment, people who are doing treatment. But it didn't mean that masks didn't work. Masks do work. They work in preventing you from infecting others, in preventing you from getting an infection, and just as importantly, it affects the severity of illness. That is, the higher the infecting dose, generally speaking, the milder the illness. So if you're wearing a mask and somebody is near you and infectious, it is more likely that you may become infected, but with a milder infection. So you have masks. That you can do. Pakistan can provide masks, not N95s, even just the concept of a mask, the concept of putting something over your face, which very conservative communities already do, at least among women. So mask, particularly if you are ill or if somebody in the family is ill. Secondly, those who are ill should not go out and circulate in the community. Wait until your infection is over. Not a COVID infection, any type of acute respiratory infection, ARI as we call it. You can't differentiate oftentimes. And so anyone who is ill should be wearing a mask and stay in the house until they're better. Hand washing, fine, except lots of places don't even have water for hand washing. And certainly soap is not widely available. So the hand washing stations may be out there, but they're not out there very long. And we know from studies in Pakistan, actually, by Steve Luby and others, getting people to wash their hands is a very tough thing to do. Thirdly, coughing etiquette. So when you cough into the crook of your hand, not out into the open environment. What about physical distancing? Well, yes, you can. You don't have large gatherings of sporting events, cricket matches, football matches, and so on. What about religious activities? Well, there's no reason that people can't go to pray, but they should maintain a degree of physical distancing and wear masks. There's nothing against the religion that says you can't wear a mask when you pray, for example, or that you have to be right next to somebody. You can still be within 6 feet and still offer your prayers. And so avoiding large gatherings where people are exposing others is easily doable. I've seen pictures where markets have been open in Pakistan and people rush to the market. Well, if you had a very good, simple type of message to avoid certain kinds of things, I believe it could have been better handled. Interestingly enough, Pakistan, Bangladesh, and India have all began their social distancing, bad term, shouldn't have used it, physical distancing and lockdown all about the same time, around March 24th and so on. The incidence of infections and the prevalence of infections is a 2 or 3 fold difference depending on where you are, but that is hugely dependent upon reporting, aggressiveness of testing, and so on. In terms of deaths, however, interestingly enough, and this is of a day or two ago, Bangladesh had about 1,000 deaths, Pakistan had about 2,000 deaths, and India had about 8,000 deaths. I'm rounding things off, okay? So maybe, given their population differences, maybe Pakistan or India or Pakistan should have had 1,500 deaths or fewer deaths. So there are differences, and one could argue maybe those differences are due to some of the policies involved. But Bangladesh, which has a population of 166 million, has only 1,000 deaths, which is about the same number if you inflated it by population as India has. All of them have followed different policies. Yes, all of them have followed different policies of physical distancing to greater or lesser degrees. The point of to summarize, the point of what we were always trying to make was, and it's not in the Hippocratic Oath, I misspoke, but the term in Latin is primum non nocere. Above all, do no harm. Above all, do no harm. And our contention is that some of the strategies that have been followed have in fact caused more morbidity and mortality than had different strategies been followed that were more relevant to the societies in question. I can also talk about Africa, but we'll leave that to later. Thank you very much. I hope that gave you enough fodder.
Yeah. In fact, I'm wondering halfway down your talk that whether you were a paid spokesman for the government of Pakistan at the federal level, because what you're saying resonates completely with what the federal government has been saying, at least.
Let me make one last point. I am not endorsing any government position, any government policy. I honestly don't care. What I'm talking about is the basic principle of context and devising and social justice. If Pakistan has lifted lockdown, but social justice does not prevail, I'm sorry, I wouldn't be particularly keen on that. Okay, I'm sorry. Enough.
Yeah. When we started off, yes, that is what we were saying also, that our trajectory, we've got very few numbers of really sick people and very few numbers of mortalities as compared to, for instance, Europe or America. However, when you look at the last couple of weeks or 4 weeks, our trajectory is actually going north. And the projections are, we are actually going to be hitting 150,000 deaths in this region of South Asia by the end of July. Hopefully that that doesn't happen, but that's where the trajectory is going right now. It's hence the anxiety, etc. So, Swalia, you may have a few questions that have been popping up for Richard. Can you sum them up, a few of them?
Yeah, so I'm just going to take, yes, I'm just going to take 2 or 3 questions. And one of the questions is coming from Dr. Farat Muazzam. She wants Dr. Cash to comment on the fact that some South Asian countries have used the global recommendations for lockdowns as a means of further violation of basic rights of citizens who are most disadvantaged. Another connection to your concerns
I'm sorry,
regarding
I couldn't hear you. Could you repeat that, please?
Okay. Dr. Richard, would you like to comment on the fact that some South Asian countries have used the global recommendations for lockdowns as means of further violation of basic rights of citizens who are most disadvantaged? Another connection to your concerns regarding social justice.
Well, yes, you're absolutely right. In South Asia, a lot of the lockdowns, and I'm talking about the 3 main countries, Pakistan, Bangladesh, and India, have in fact abrogated individual rights. They've been pushed aside. These lockdowns have oftentimes been imposed by security forces, police, and so on, not by public health. Now, what about those 2 countries that I mentioned? I'll leave Nepal to the side, Sri Lanka and Kerala. In both of those, social justice, in fact, has been kept. Individuals have been, they're both highly educated populations. They began early. They provided means to their citizens. There was almost no pushback from the citizenry who were brought into the process the whole time. If you want to look somewhere as to where it has worked and where it has been properly implemented, look to the south of South Asia. That's where it seems to have worked extremely well. But both of those countries, or the state of Kerala and the country of Sri Lanka, began very, very early with an effective public health intervention and a very good social network structure that assisted people. That is very, very different than when we talk about most of, not all of, most of Bangladesh, Pakistan, and India. So yes, human rights have been violated. I don't think there's any question about that. And social justice, in fact, one could argue, has gotten worse, not better.
2 more quick questions. One is from Dr. Minhaj Kidwai. He asks, what were the main causes of mortality in Boston? Age factor, more mortality, 7,000 is a high number.
Well, I think, again, context is everything. In our state of 7 million, which again is 30 times less than Pakistan, many of our elderly have been in chronic care facilities and old age homes. The average age of death in Massachusetts is 82 years. 82 years. 62% of deaths have occurred in these chronic care facilities. There are hardly any deaths in people under 50 years of age. So our demography, which is many fewer young people, many more old people, and the way the old people were in fact cared for explains, in my view, a lot of the mortality. That, and also there are other factors. We, like New York City, are an older city. A lot of people use public transport. So the disease spread before, in fact, people were aware that what was going on. We started late, and then you play catch up. And we are just catching up now, but that's only after 3 months. I've been confined to my house, not by law, but by design or by voluntary for 3 months now.
Dr. Amir, I think we should move on to Dr. Moodley's talk. We have a couple of more questions, but maybe we can take them towards the end of the webinar.
That's what I was going to say, that we've kind of run a little late. So I think we should go on to Dr. Moodley's talk, and then we'll take more questions. Dr. Moodley, over to you.
So good morning, good afternoon, good evening, wherever you are. Thank you for the invitation to join this interesting webinar today. And I think much has already been said, and I concur with what Dr. Richard Cash has already discussed in terms of approaches in different parts of the world. I think we've seen that COVID-19 has raised challenges throughout the world. And when we think about low middle income countries, however, we have to take social, political, and historical contexts into account. As you can see, the African continent is heterogeneous. It's, each country is different, and each country has a unique context and a different healthcare capacity, as well as different approaches, especially where pandemic planning is concerned. This slide comes from the African CDC, and as of today,
your slides, Keymanthri, your slides are not being projected.
They're not being projected.
You haven't
Screen share.
Okay, so I did. Is it working now? Share.
Dr. Moodley, do you want me to project it from my end? If you
Yes,
were
you
unable
can.
to do so. All right.
Just does it work now?
Yes.
Yeah. Yeah.
Yes. Okay. So if you can see the slides now, then that should be fine. So
on full screen there.
Is that better?
Yeah.
So this particular map of Africa shows that we've had over 200,000 deaths, over 200,000 cases reported, and just over 5,500 deaths are reported on the continent. You can see that the majority of cases are coming from Egypt and South Africa. So we have 52,991 cases as of today, and 1,162 deaths. Now, in addition to COVID, the African continent also has many other important diseases like TB and HIV, and South Africa in particular carries 17% of the global burden of HIV. And while initially it was thought that HIV would be protective, we've now realized that it does not particularly protect people who are on antiretrovirals from COVID. And so if we look at all the deaths in South Africa, 1 in 10 affects an HIV positive person. But in addition, these patients also have other comorbidities like hypertension and diabetes. We also have a huge burden of tuberculosis on the continent. Now, in the early stages of the disease, Taylor et al. Published in The Lancet this particular profile indicating the severity of disease. And as you can see, right at the apex, we have the 5% of people who are going to require intensive care, mechanical ventilation, and these are the severest cases. And then below that, another 15% who will require essential care and oxygen. And of course, a large proportion that Richard referred to earlier who will require ambulatory care and will have mild to moderate disease. Now, in countries with large populations, 5% is significant. So in South Africa, that would amount to 3 million of our population who will require intensive care or ventilation of some sort, whether it is mechanical or non-invasive ventilation. And we need to be mindful of the large numbers that are involved in different parts of the world, especially in low middle income contexts. But when I saw this diagram, it reminded me of something else. It reminded me of a pyramid described by Prahalad and Hart in 2001 in their very well-known book, The Fortune at the Bottom of the Pyramid. Now, while the pyramid they described was one relating to global wealth, with the top people at the top of the pyramid being the most affluent with access to healthcare and access to various other goods, the people at the bottom of the pyramid made up the majority. And if you look at the global numbers, 500 million at the bottom, but 4 billion at the base, 2 billion in the middle, the majority of the global population sits and exists at lower levels of socioeconomic income. Now, it's really important to consider the middle and the base of the pyramid, because these are the people who require healthcare, who do not have access to healthcare. And they require healthcare not only for COVID, but also for non-COVID related illnesses. And I think understanding and being mindful of the balance between treating COVID and treating non-COVID illnesses during this pandemic is really important. Now, the difference between the apex and the base of the pyramid is the socio-economic inequity that we know exists in many low middle income settings. And it is measured in various ways. We know about the Gini coefficient, which ranges from 0 to 1. And the closer to 1, the more unequal the society is. South Africa has the highest Gini coefficient in the world, sitting at 0.95. And we have huge disparities in terms of socioeconomic levels, in terms of access to healthcare, housing, sanitation, water, etc. So it's a country of great contrasts. Very early on, in fact, in early April, people were becoming concerned about how Africa would cope with this pandemic, given that we have much fewer doctors, fewer ventilators, etc., compared to more well-resourced nations like Europe and the United States, that was really not doing well in the face of the pandemic. So the one important question raised was, will younger populations in Africa be able to save the continent? We have a median age in Africa of 19.7 years. And in South Africa, the median age is 27.6 years. Sadly, we have found that amongst our deaths, 2/3 of deaths are occurring in people under 65 years of age. And these young people have comorbidities like obesity, diabetes, and hypertension that are more prevalent in older populations in other parts of the world. So although Africa has a young population, we have a young population with a high prevalence of comorbid conditions. And so our deaths are occurring in much younger people. Admittedly, under the age of 20, only 2% of deaths occur, as Richard has indicated. But as we move up, we find that between 30 and 60 years, we have a fair proportion of deaths in our setting. Now, most of the allocation frameworks in pandemic planning emphasize the importance of taking a utilitarian perspective. So saving the most lives and saving the most post-treatment years of life. And that has been quite a standard approach. And in many cases, this utilitarian approach has been applied to the top of the pyramid, to those people requiring ventilators and ICU beds. And to a large extent, the concept of utility has not been applied at a broader level, where we have to look at the number of lives to be saved throughout the pyramid, and especially the middle and the base, in terms of age, but also in terms of other non-COVID related illnesses. So in Africa, we have very few ventilators. This point has already been made. In South Africa, for our population of about 60 million, we have 7,000 ventilators, most of which are located in the private healthcare sector, where we have a dual healthcare system divided between public and private. And even more concerning is that 10 African countries have no ventilators at all. So this is important in some respects, and maybe not that important in other respects, especially now that it has been found that mechanical ventilation is not necessarily the best option for people presenting with SARS-CoV-2 infection. In spite of this, there is a specific proportion of people who will require access to ventilators. So although in South Africa, we've already moved towards non-invasive ventilation, non-invasive ways of providing oxygen, high flow oxygen provision, etc., as a more important approach than mechanical ventilation, there are a proportion of patients who still require ventilators, and our ICUs are filling up. But ICU capacity is not the only option. There is a lot more we need. If you have a ventilator and an ICU bed, you also need medical personnel to manage that bed and that ventilator. And this is where we're having major challenges in ensuring adequate number of critical care nurses intensivists and ICU doctors. And so the human resource is really important and under threat. Also because our healthcare workers are becoming infected with the virus, possibly due to the exposure, the excessive exposure to positive patients, close contact over prolonged periods of time, but also inadequate PPE in some instances. And so if we look at doctor to patient ratios, we can see the very extreme differences if we move from Italy and Europe to South Africa, and it just gets worse if we go to Somalia and look at how few doctors there are to service large numbers of patients. So healthcare personnel are in dire need during this pandemic. But in addition, we need to ensure that we have other measures in place, and testing and isolating and contact tracing is an indisputable public health measure. However, we are struggling. So although our initial goal in South Africa was to ensure that we conducted 36,000 tests a day, we have fallen far short of this. Turnaround time ranges anything now from 5 to 14 days. And we would prefer that it were turnaround time of 24 hours. So there are some specimens sitting in laboratories that have not been tested yet. And of course, in terms of South Africa being a low middle income country, procurement is a problem. So we stand last in line when we look for test reagents and consumables, which are also running out in the same way that PPE is running out and not easily available. And so let's go back to the pyramid and think of other principles that have been associated with the pyramid approach by Prahalad and Hart. And of course, physical distancing is a huge challenge because, as we've discussed already, how is this possible in overcrowded urban settlements, in informal housing where many people share the same residence? And this brings us to the next principle, which is important in using the pyramid approach, and the importance of combining local and global knowledge, not simply importing knowledge from the global north and implementing it in contexts where it does not work. And so clearly we need to ensure that there is a level of community engagement and that we understand what is possible and what will work best in terms of prevention. We've heard about masks, and I agree with Richard in terms of masks initially not being emphasized for the general public. And yet today in South Africa, wearing of masks is required in all public spaces by everybody, all of civil society, not only healthcare workers, although we are reserving the N95 masks for our healthcare workers on the front line. And so there are many other principles important in thinking about the bottom of the pyramid, and the concept of trust is important. And this is critical in Africa. We're all aware of the comments made by 2 French doctors earlier on in the pandemic, indicating that Africa would be the ideal place to test interventions, including vaccines. And needless to say, given the long history of exploitation of research participants in Africa, this has created a great deal of concern around trust. And will people in Africa again be used as guinea pigs to test various interventions that may not be made available to them once they are found to be efficacious? And then the other important concept is around harnessing indigenous knowledge and traditional medicine. And in this age where we have a well-established system of allopathic medicine, yet for COVID, there is no intervention known to work. We do need to take other systems of medicine into account. This has already happened in Madagascar, where they have developed some formulation from the Artemisia plant. Now, artemisinin products have been used in malaria. What is interesting in this particular case is that this medication or phytochemical is under trial at the Max Planck Institute in Germany. And it would be interesting to see what the findings are, because we would not want to advocate for a product that would cause harm. But if it is found to be beneficial, that would be wonderful. And we also have to harness the knowledge of communities in terms of how they deal with infectious diseases. So when I was very young and I had measles as a young girl, I distinctly remember what my grandmother did. I was put into a room all by myself. It was a dark room because measles, as you know, involves a conjunctivitis, so you become light sensitive. So curtains were drawn, it was a dark room. You stayed in that room in one part of the house. There were a whole host of home remedies to treat the rash, etc. And there was a brass container that was placed outside the front door with turmeric water and a leaf from what we in South Africa call the syringa berry leaf tree. And that was a sign to the public or to neighbors, to anybody else, that there was an infectious disease in that home. And so you did not enter that home. Shoes were kept outside. And so a number of measures were put in place. So there is traditional knowledge that is important and valuable when we think about infectious diseases, and we need to learn to harness that knowledge and encourage communities to practice those measures. What is important is that when we look at the pyramid, the difference between the top and the bottom is that today technology is helping to narrow that gap, especially mobile phones, mobile technologies that are allowing contact tracing, development of apps, and in some ways, forming a way in which we can communicate information to people. We have many in South Africa, many messaging websites that have been developed, many apps that have been developed. And to move even further in terms of innovation, what we have always wanted is innovation to arise from the African continent. And so Senegal has developed at the Pasteur Institute a quick, easy and cheap way of testing for COVID. And we want these types of innovations to assist. So in other words, knowledge derived from the contexts in which the infection occurs, as opposed to having imported knowledge. So as Amber indicated at the end of her talk, solidarity is really important during this pandemic. And even if one country has the disease, the rest of the world is not safe. And this is really important. We've also seen a very interesting perspective on herd immunity published recently in an editorial in JAMA, where we usually think about herd immunity in the context of vaccines. And obviously the more people who are vaccinated, the better our herd immunity. But this new kind of herd immunity is not about vaccines. We know that what is important is that any society needs to value its most vulnerable members and ensure that they are protected. Because if they are not protected, there are devastating health and economic consequences for all. But the herd immunity referred to here is the kind of herd immunity where resistance to the spread of poor health in populations occurs, because a sufficiently high proportion of people in that society have access to good health and are immune to the negative social determinants of health. And this is why we need to bridge the gap between those who have and those who do not. We need to find ways to deal with socioeconomic inequity, because that lies at the basis of all the problems we are encountering with COVID today. So there is in low middle income countries a pre-existing level of health inequity. And COVID is only magnifying that inequity. So to try and solve the problem by using the measures we are trying to use now is only equivalent to putting a Band-Aid onto a problem that has much deeper roots. And so clearly in the post-COVID era, we need to seriously think about how we will address these issues. I'd like to acknowledge a number of my academic colleagues who have worked with me in developing the idea around the pyramid in our approach to COVID. And in particular, one of our co-authors, Professor Patrick Kaimbe from the Kinshasa School of Public Health in the DRC, who died a few days ago. And it's a reflection of how short life is and how people we know are becoming more and more affected by COVID. And so we are moving from the context of looking at statistics to now looking at real people that we know who are afflicted by this disease. And so the challenge for low middle income countries is to ensure that we work towards reducing inequity in healthcare and reducing socioeconomic inequity, because without that, pandemics will ravage the continent. Thank you.
Thank you, Dr. Moodley, for a very, very interesting talk. And you've highlighted many of the things that actually Richard has also been talking about and what Amber has been speaking about, and how this pandemic has actually exacerbated the inequalities and inequities across the world, whether, although the virus will can attack anyone, whether rich or poor, but the impact on the poor is much, much more devastating individually as well as collectively than it would be on the rich person. And so I'd open up for questions, a couple of 2 or 3 questions for Dr. Moodley, and then we can perhaps take another 2 or 3 for the entire panel, because we are running over time.
Okay. Yeah. So there's one question from Dr. Muslim. She's asking, well, she first thanks you for sharing the African experience with COVID. The particularities and context within our part of the world get insufficient global attention. Would you comment on how South Africa is handling non-COVID patients who are at the base of the pyramid? We are struggling with this issue in Pakistan.
Yes, so I think that's an important question, and we're dealing with that at our hospital at the moment. So we have the surgeons on the one hand who have surgical lists, and then we have the ICU doctors who need critical care nurses. And so the first approach is to say, shut down theater lists so that we can release critical care nurses to come and assist us in ICU. And now the surgeons have rebutted, and their position is that if we close down a surgical list for a week, we would harm 100 patients who needed not emergency surgery, because emergency surgery is continuing, but rather urgent surgery that is nevertheless important. And if we shut down a theater list, we would only be releasing 4 nurses to the ICU to nurse 4 critical care patients, 2 of whom most likely will die. So at the end of the day, we've got to play this numbers game against, are we going to save 2 lives with COVID in ICU, or are we going to continue with our surgical lists and ensure that 100 people derive benefit or are spared from deterioration? And I think it's this balance. How do we balance the COVID and non-COVID obligations in this pandemic? That is quite a challenge within healthcare in South Africa.
Another question from Dr. Minhaj Kidwai. He asks, are there any clinical trials going on for artemether? Has it been tested in Senegal?
Yeah. So artemisinin is being tested in Germany at the Max Planck Institute, we are told. We have not got results as yet. And so we're looking forward to it. As far as I know, Senegal is not testing it, but it is definitely in some kind of clinical trial at the Max Planck Institute. Although many people in the community are using it in the absence of anything else. And there are always safety concerns if there's a product that is untested.
We have one generic question, I think, which can be opened up to all the panelists. So what should Pakistan and other South Asian countries and also South Africa do now to tame the pandemic? Given that we...
That's all we need to know, yeah. That's a very unfair question, but maybe the panelists can have a shot at that. Richard, you need to unmute.
Can you repeat the question, please?
Given now that we have this number of cases and we've had this discussion, this is a question from Dr. Natasha Anwar. What should Pakistan do now to tame its pandemic? And of course, this can be extended to other South Asian countries and South Africa.
That's for all of us. You want me to take a crack at it, or? I mean, my own feeling is that if they continue on with the making sure that people understand that that crowding together is potentially harmful, that mask wearing in certain circumstances is appropriate, and that hand washing when possible, the simple interventions and the awareness, I think, is what you need. I don't think that the issues of enforced physical distancing through the strategy of lockdown has frankly done much of anything to reduce the spread of the condition. I think it's continued on anyway. And so again, going back to what I've suggested, don't do any harm in trying to stop this. This epidemic is going to play itself out, as all of these have, whether it's H1N1 or SARS or what have you. My guess is that by the end of the summer, particularly as people increasingly go outside, which they have to do given the heat of the time. I mean, after all, the temperature in Karachi right now, I would guess, is probably 35 or something like that. I don't know, but you can't ask people to do things that they will reject. Remember, public health only works if the public agrees to it. If the public rejects it, then you can't. If the public does not want to take your advice, then they won't take your advice. So the advice must be done with consultation with the community. There may be some communities where there's a lot of spread. Those communities you can possibly do testing and so on. But to do it nationwide, I don't think that will do much good of anything and will not help the situation. You know, sometimes doing the minimal is really the maximal. Sometimes less is more. And I'd like to say one last thing again. We're talking about mortality here. The deaths per million in Europe and the United States runs anywhere from 100 to about 500, roughly. In South Asia and in all of Asia, it's less than 10 per million. And in sub-Saharan Africa, it's even less than that. So yes, there may be undercounting. Yes, we may be early in the epidemic, but those numbers are profoundly different, profoundly different. And I don't suspect that over time they will change dramatically. In sub-Saharan Africa, people are outside a lot. There are much more spaces. There are different demographic profile, as Keymanthri said. It's a very young population. The average age is under 20. In Europe, it's around 40. That's huge. That's a vast, vast, vast difference. So the demography and the way people live may well act as a type of prevention, which is perfectly fine.
So Richard, what you're saying is that it will just play itself out, and our numbers are very different. However, the trajectories in the past few weeks have shown the numbers are dramatically increasing, but let's hope that you're right. Does the concept of herd immunity actually come into play in South Asia, and when will it actually be any effective remedy or protection, if ever? So maybe Amber, you could take that and start off with that. I'm talking of herd immunity as a helpful factor for Pakistan, India, Bangladesh, Africa, and LMICs.
To work and there are different estimates for SARS. It's between 60% to 80%. That the population needs to be for herd immunity to work. The antibodies should be present in 60 to 80% of the population. Now, there are two ways to get those antibodies, right? We know either you get vaccinated or you get infected. So infecting 60 to 80% of the population in the hope that you will get herd immunity is not the best, strategy in my opinion. Just look at the population of these countries. Number two, whatever we say about mortality figures in India, Pakistan, and Bangladesh, even 2% or 3% of these cases, if they end up going to hospitals and exposing all healthcare workers to this infection, just imagine the chaos, and we are already witnessing it. So letting people on their own so that, young people would get infected, they would, recover and have some kind of immunity. What we don't know is that how long this immunity would last. Is there a possibility that it lasts for a few months or a year, or it doesn't happen that they get reinfected again if they're exposed to an infected person? So we don't even know about that. So herd immunity is, and we also know that Sweden, said that they would actually let their people go outside, mingle among themselves, and young people would get it. They would surround their elderly population. So sort of protecting their elderly population because they have antibodies. It didn't work. And until now, they have not even a double figure of their population who have antibodies. So in theory, this sounds very exciting, but in reality, it may end up having a much more chaotic situation in which your health systems would be completely under, jeopardy by this approach.
Amir?
Yeah.
Amir, may I comment for 1 minute on this?
Certainly.
Yes, I think the term herd immunity is badly used. It's herd protection. You are not immune if people next to you are immune. So you're protected, but you're not immune. Secondly, the figure of 60 to 80% is a wild guess, like a lot of the models that have been out there. Bangladesh modelers said 500,000 people would die by May 26th. There were less than 500. We don't know why a lot of these diseases disappear. Certainly when H1N1 became a milder disease, we were far, far, far below 60 or 70%. So these numbers create fear, but they are not based on, they're models. That's what they are. And for most of the upper respiratory infections or lower respiratory infections, these conditions have become endemic at far, far lower rates of immunity in the population. I would guess it'll be less than 10%. I think 60 to 80% is absolutely crazy. And if you recall, the Imperial College initially estimated that 7 billion people would have to be infected before this came under control. Well, where they got that from, who knows? Who knows? So that's my opinion.
Dr. Keymanthri.
Yeah. So Amir, I think what was important in South Africa, we did have an initial lockdown. It was useful because it helped the healthcare system to prepare. We have developed a field hospital, and several of them improved our ICU facilities. The health system needed to be ready to accept those patients who required hospital admission. And in our case, it's young people who are getting severe illness, young people who are dying. And so it's important that there is a level of preparedness at the level of the healthcare system. Part of our lockdown included a ban on alcohol. And what was interesting is the number of admissions to hospital for alcohol-related deaths, alcohol-related trauma dropped significantly during the period of lockdown. But when the ban was lifted now, the hospitals are once again being flooded with trauma victims related to alcohol abuse. And so we are now having the alcohol-related illness competing with COVID. And so this again has become, it's currently a huge source of contention in the country, because our healthcare system at this stage cannot really afford to have so much trauma related to alcohol.
I think we got several other questions, but I think we've run significantly over time. But we have a lot of participants still going along with the webinar. But I think it would be unfair on the participants as well as the panelists to prolong this further. So I'd like to thank Dr. Amber, Dr. Moodley, and Dr. Richard for contributing their thoughts. Obviously, there are no easy solutions for anything. This is a highly still a very evolving situation. We really don't know what next week will bring and what new modalities will be there, etc., etc. But the thought process and the dialogue must continue. This has in Pakistan become extremely politicized also, with the governments of various parts of the country fighting with each other. So we have to sort that out also. The general public, even those who wear masks, wear them on their chins rather than on their face for whatever reason. So there's an entire situation of disbelief that it won't happen to me. Even though you've got your ICUs that are full, you're crying over that people are dying on the streets. However, you will not do physical distancing. You will not take precautions for yourself or your family members, etc. So these are things that we need to sort out in all over the world, including certainly in Pakistan. But I think all three of you have contributed tremendously to our thinking. And on behalf of the Center of Biomedical Ethics and Culture at SIUT and our faculty over here, and on behalf of the participants who've been joining us from all over the country, all over the world. In fact, many people from Africa and other parts of the world, our alumni, our current students. So thank you very much. And we hope to be in connection with you in future. The video recording of this discussion on the webinar is available on our Facebook page. So please go like our page. We like people who like us, and stay connected. Thank you very much.
Thank you.
Bye-bye.
Bye. Bye-bye.
Bye-bye.
Stay safe, everyone.
Thank you.
Bye.